a consultant neurologist in Christchurch Hospital, as you all know her, well known in MS and in MS researchers. I would say the queen of MS and rehabilitation. Debbie is also involved as a university lecturer, Department of Medicine, University of Otago in Christchurch, and also does lots of research with NZBRI, New Zealand Brain Institute. Over the last 3 years, I witnessed a lot of you guys' great connection with Debbie, and we had the pleasure to work closely. She's a good advocate for exercise, so we get along really well. Yeah, so she's been starting this Ask Me Question series over the last 2 years, which is great. For people with MS, I guess when you get diagnosed, there are two things. One, having a good medical team, good neurologists, good nurses. And the second thing is having a good community. We are pleasured and honored to have this beautiful building and MS and Parkinson as a charity to provide all of these services, keynote speaking, exercise, support groups, and also a great team in the hospital with MS. In fact, when we had the MS conferences, everybody's surprised to see how much support people get in Canterbury compared to other regions in New Zealand. Yeah, without further ado, I will ask Debbie to give us everybody a big round of applause for
All right, thank you so much. Can everybody hear me? Yes, great. All right. Well, listen, thank you all very much for your questions. What I've tried to do is I've looked through the questions and I've tried to just kind of pull out things that I thought people would be interested in. And then, as I said, we'll have some questions at the end, and I know there are a few things that I didn't have time to cover and things, and we can answer some of those. I'd just like to reiterate what was said and the importance of community, and particularly in our changing environment at the moment with less and less time for patients in hospitals, large wait lists and things. I think that the work that support people and charities do is just amazing, and I think that it really creates a very great service around people with these diagnoses that not all services have, unfortunately. So without further ado, I will, so these were the sort of topics that I picked up on that people wanted to know about. I thought that I would talk about the new ocrelizumab subcut because I know that people are interested in this. Progressive MS, I think, is something that interests lots of people, and there have been some interesting changes in the last 2 years around that. So I thought I'd spend a little bit of time on that, and that leads into a couple of trials that have become available as well. People ask me a little bit about if I'm diagnosing somebody, how do I tell if it's MS or another type of demyelinating disorder, what we call MS Nimitz. So I've got a few slides on that, and then if we've got time, we can talk about symptoms and medications and things like that that people are interested in. So let's talk a little bit about ocrelizumab first of all. So many of you have been around a long time, and you will remember that when the research really took off initially in MS, it was all about T cells. We were all looking at the immune system and we were looking at T cells. And then about the early 2000s, people like Amit Varor and a few others out of Pennsylvania started saying, well look, you know, maybe B cells also play a part here. And that has turned out to be true. And what we can see here is this B cell, and that it has quite an intimate relationship with the T cells. And it probably also participates in the inflammatory things that happen in MS. And so then somebody said, well look, what if we knock out the B cells? And everybody's like, oh, that's not going to work. Well, it did. And so this CD20, that's just a marker that sits on the B cell, and so that the drugs know which B cells to pick on. We'll talk a bit about that with ocrelizumab. But it turned out that actually by knocking back B cells, you could treat MS, relapses, inflammation, changes on MRI, as well as you could with some of our T-cell treatments. So that was a big thing, and so what then happened is that largely Roche, who kind of gave me these slides, then developed a humanized antibody, and that antibody links onto this CD1920 marker, and it then kills off the B cell. And once they did the clinical trials in that, they found that it was equally, if not slightly better in terms of efficacy than the treatments we already had. And so we've now, in the last, so 2015, it was licensed in New Zealand, and a little bit after fingolimod, and we've seen a huge increase in our use now of B-cell therapies, and ocrelizumab is the one that we use the most. Rituximab is used in Sweden and overseas, but ocrelizumab binds a little bit harder than those other drugs. So at about the same time as all this was being done, a lot of our colleagues in rheumatology, immunology, lots and lots of other diseases, SLE, were also using a lot of these drugs. But of course it takes a lot of time. You have to come to the hospital, infusion times are long, 5 hours, there's a lot of equipment associated with it. But the technologies were moving forward for subcut, so being able to inject the drugs directly into the tummy and shorten the time frames and not have to get IV access all the time. And when I was doing my fellowship in London in 2023, they have a drug there which we don't yet have in New Zealand, which is a B-cell treatment that patients put it in every fortnight at home. What we have now is one that we inject into your tummy, and we'll talk a little bit more about that. But basically the technology is that we put a little needle in the tummy with a little pump on it, and what it is it's this hyaluronase, which is a substance that breaks down temporarily some of the links amongst the cells in the subcutaneous tissue. It allows a little pocket where we can put 23 mils of fluid, which then dissipates in and around and gets into the systemic circulation, doing exactly what the IV drug does, and then it all heals over within a couple of weeks. So Roche again thought, well, actually this might be something that's really good for patients. I wonder if we could do it with MS treatments. And so both they and Biogen with natalizumab, who also have a product like this now, which we don't yet have, they then said, well look, we've got to prove that it's as good as the IV drug, because people are going to say to us, oh, Dr. Mason, I'm not sure about that, I think the IV is much better. So the trials were done, and they worked out that you need about 920 milligrams of the subcut compared to the 600 milligrams we use IV, and when you do all the trials, you get exactly the same benefit to the patients. So Pharmac funded this as of December last year, and Auckland have, I think, 35, 40 patients that they've transferred over, and we just started 2 weeks ago, and we've also been moving people over to the subcutaneous form. Where do we do it? We just use the tummy. As I said, it's a little needle, and it goes in either slow push by the nurses or a pump, and it sits in there, doesn't cause a lot of problems. Sometimes you get a bit of redness and things, I'll show you that. But it's a 10-minute infusion, not 5 hours. So this is where the benefits are going to lie. You still get the pre-meds with the tablets and with the antihistamines, which we do half an hour before. Then you have the infusion, and then you hang around initially for a short period of time just to check if it's the first one that you're okay, but then you're off. And so the whole thing, probably an hour by the time we've done everything. So a big change for people with busy lives. So what are the side effects? Well, you can get these erythemas or site reactions. Now some of you may remember the old, see our young patients, they don't remember this anymore, but remember beta-ferron and capaxone and things that you all used to inject. Then the same sort of thing. So you get a little bit of a reaction sometimes. Sometimes it can be a bit bigger, but we just put a cool pack on it and it all resolves. It can be a little bit uncomfortable. We ask you not to wear too many tight clothes for a little while. Bit of itch. And then the headache, nausea and flushing are very much just the sort of thing that we get with the other medications. And the reactions that do occur tend to withdraw over, sort of reduce over time. So that's good too, that if you get a bit of a reaction the first time, it doesn't mean that you're going to keep getting reactions. They often get better. All right, so is there any brief questions about that before I move on to talk about progressive MS? Anybody have any particular questions? What the nurses are doing is that when somebody is coming up for an IV infusion, we will contact you beforehand. We will give you the patient information. You've got time to sort of mull it over, ask any questions about it before you come in. So people, you know, it's not like you turn up one day and we go, oh, we're going to do this. If we do, our system's broken down. All right. Listen, let's talk about progressive MS because I know this is an area that interests people a lot. So I think if I was to update you in the kinds of changes that we've noticed over perhaps the last 10 years, is that it would be fair to say that the treatments that we now have for MS have been very, very effective at reducing relapses in people, so acute attacks, and also inflammation that's new on the MRI. So lesions tend to reduce significantly with the new treatments. But what happened when we eliminated the relapses and the noise with the changes in the MRI is that we noticed that people still progressed. And this is called progression independent of relapses. PIRA is the kind of the American name for it. And there's been a lot of discussion about why that is, and we still don't fully understand it. I think my next slide shows that there's a lot of things that play into it, and we still can't predict who might progress and who might not, despite being on very effective treatments. And part of the reason for that is that there are probably heaps and heaps of reasons why people might be more susceptible to progress than other people. And some of those things are things we can do something about. Smoking, obesity, low vitamin D. But some of the things you're kind of stuck with, you know, if you're a female sex, that's just the way things are. And what we know is that some people remyelinate really, really well, which is probably something about their own individual immune system. And some people don't, and they just get a lot of loss of axons and things like that. And so you get this high chronic inflammation with some mitochondrial dysfunction, people who are older in age when they develop MS, delaying in treatments, those sorts of things all play into this. But the other thing that we've also identified is that you will remember from previous slides that I've shown you is that when you have a relapse, what happens is that the immune cells within your body move into the central nervous system, into the brain or into the optic nerve, and they create this inflammation. They have a party and basically cause inflammation. What we think happens with progressive MS is that these are cells that are already in the brain, and they smolder, and they just have this low-grade inflammation. And the problem with that is that most of the drugs we use actually don't get in across the blood-brain barrier. So natalizumab blocks lymphocytes from going in. B-cell therapies, Ocrevus, takes out the B cells in our blood system, our systemic system. Fingolimod holds the boy races in the spleen and lymph nodes and stops them going out and causing trouble. But very little gets across this blood-brain barrier. Tecfidera does to a certain extent, and some of our older treatments that people were on, betaferon and buterina, do. But we think that most of the progression is because of ongoing inflammation within the brain that our current drugs are not accessing. So it's been quite exciting that there has been, I've been involved in progressive trials since when I was in Canada, so 1999, 2000, and I think there've been 16, 20 trials in progressive MS. All of them have been a bust. But the Hercules trial, which was done just at the end of last year, or published last year, looks like it's the first trial that is actually showing benefit in people with secondary progressive MS. And we think that's partly because the drug that is a tablet, this tyrosine kinase inhibitor, actually gets into the brain. It goes through the blood-brain barrier and gets into the brain. And what that showed was that it's the first trial that we've seen, and it seemed to delay disability at 6 months by about 30%. And so in patients who'd had progression over a year and weren't having relapses, so didn't have active disease. So the MRIs didn't show new lesions or any gadolinium enhancing lesions. There was a little bit of problems with liver toxicity, but those things we can get around by monitoring quite closely. So this is a trial for people who had relapsing onset MS and then have developed progression. But also coming out of that, and we don't have all the answers yet, is we used to talk about primary progressive MS and secondary progressive MS, and we did it in a kind of a dichotomous way, if you like. But I think more and more now we're thinking more about inflammation that's contained within the brain that causes progression, and inflammation that is relapse driven or driven by sort of inflammation from the systemic circulation. And that may be why, in a way, ocrelizumab has been shown to have some modest changes in people with progressive MS from the get-go. These drugs are still not cures, but it does mean that for the first time ever we're beginning to start, and that's where we started with relapsing MS, and look where we are now, 15 years later. So as I said, this is this they call it a BTK inhibitor, and it basically what it does is it kills off these B cells, but it stops them within the brain, and it acts not so much on the oligodendrocytes and the inflammation, but on this microglia, which we think is what causes smouldering, ongoing disease activity. So, there's that it gets through the blood-brain barrier and it can get in to look after the oligodendrocytes. It reduces the cytokines, which are all the inflammatory cells, and it also inhibits these microglia, which are sort of chomping away at the axons. We haven't seen trials in progressive MS in a very long time. We've done a few, but not that many. But we now have trials starting to come out. So this is 2 trials that I'm going to be part of here that we might be starting later in the year. And it will be done not through the hospital this time. Hospital trials are just about finished now, unfortunately, but we'll be doing it through Optimal, one of the private places just by the hospital. So this is the Monarch trial. We're going to include people between 18 and 60. It's phase 3. It is placebo controlled, so there'll be people on drug and people on no drug for 2 years. And you have to have secondary progressive MS where it has progressed over 2 years without any ongoing inflammatory activity, either by MRI or by relapses. And because we need to be able to assess whether the drug is working, we need people to be at certain stages so we can follow them over 2 years and measure progression. So you have to be able to, for this trial, walk at least 20 metres with either unilateral or no support or a little bit of support. So that's the Monarch trial. The Mentaki trial, again, this is a slightly different trial. This is looking at whether this product, which I'll just call Maggle because it's too long, which also gets into the brain, when used with ocrelizumab, also helps with neuroinflammation and helps promote remyelination. So this trial is going to be for people who are already on ocrelizumab or who can go on ocrelizumab. So not a placebo-controlled trial. Everybody will be on ocrelizumab, but the placebo portion will be the fat cell, this lipase that we're going to add in. Again, similar kind of criteria, 18 to 60, have to be relatively newly diagnosed, 10 years, but 20 years with secondary progressive, moderate disability, have to be able to walk 100 metres with or without a stick, and again, progressed over the last 2 years with no relapses. So these are things which I think are really exciting. We don't know if they'll work or not yet, but this is the first time we've sort of started to see some trials that may well be beneficial for people who have got to that stage where they're not experiencing a lot of relapses, but they're noticing that their disease is progressing anyway. So, you asked me to talk about MS mimics, and I think this is a really exciting. You know, in the old days, everything that was demyelinating or that looked like MS was MS, and we've now come to realise that we probably misdiagnosed a few people, and probably I have too, and that we are now beginning to see diseases that can mimic MS that are not MS. And we've been helped hugely by what we call new cell-based assays, so we can test for a lot of these types of diseases now. And I think that there's sort of increasing recognition that there are other kinds of neuroinflammatory diseases, but I want to emphasize they're incredibly uncommon. So they probably occur 1 to 2 people per year every 100,000. So these are not common diseases. And some of them tend to be more common in some cultural groups, for example, Asian people and Maori. It can be difficult to make a diagnosis of these alternate ones, even with our assays. And we rely a lot on the sort of clinical experience of our people, like neurologists. The spinal fluid and MRI can be helpful for us, and I'll show you some examples of that. So the two common of these uncommon diseases is MOG, what we call anti-MOG disease, or MOG, which is myelin-associated glycoproteins, and neuromyelitis optica spectrum disorder. And those are the two that we probably see. Yeah, I know, exactly. And they're relatively new, so the clinical syndromes are evolving all the time in terms of our experience and knowing what might be and might not be. And that's where being in the game, like me, for a long period of time starts to, I remember 10, 15 years ago, seeing patients, and I thought, this is something, but it's not MS, and this is where we're beginning to see these things. So they're quite different. So MS causes demyelination and progressive injury to our axons, and patients have an attack and then they can progress. But these two disorders are discrete attacks and then it's over until the next attack. They don't seem to progress. And that's because this one attacks the oligodendrocyte rather than the myelin, and this one tends to attack water channels on the surface between the where the little foot plates come down onto the myelin, and hence the difference there. So how do we tell them apart? Well, there are a few things. The MOG ones tend to, whereas MS is more female prevalent, this one can occur in both males and females. It's much more common in children, where it's called ADEM. And adults present with optic neuritis and myelitis. They don't tend to get cerebellar features, tremor, incoordination. They tend to get optic neuritis or spinal disease. But optic neuritis is certainly one of the most common. So now if a person presents with optic neuritis, we now do the testing for this condition. It's typically bilateral and it's often quite severe, and it's exquisitely steroid responsive, which is again another clue to the fact that it might be MOG. But you can see that the scans that we do are a bit different from MS. They're often much bigger areas of change. They do, like MS, come around the bottom of the cortical structures, but this just looks different from typical MS. But it can be very difficult because that could be MS too. Then neuromyelitis optica, first identified in the Mayo Clinic in 2005. And again, as I said, it's this water channel that sits on these astrocytes. This one is very female predominant, so a male with NMO is quite rare. Again, still comes with optic neuritis and with spinal disease, so myelitis. And again, often bilateral. Most optic neuritis in people with MS is one eye. These often come with bilateral symptoms. And again, the MRIs look a bit different. They tend to occur, so eyes up there, this is a cross section, this is the brain stem, and they have these little things at the top of the brain stem, and like this. And rather than having what you might have remembered as the Dawson's fingers, which is these big areas of demyelination that stretch out like hands from this structure, the corpus callosum, they tend to just have this kind of more lumpy look. And this is a spinal cord, and what you can see here is from there to there is all inflamed. Now that would be extremely rare in MS. MS lesions are usually just sort of from there to there or there to there, just very short lesions. So those things do help us a bit. And then in 2016, there's yet another condition. This one is incredibly rare. I've only heard of 2 cases in New Zealand. And this one is what we call GFA. And it is again, attacks the astrocytes. Usually comes with sort of some cognitive difficulty. They have like a meningitis type presentation. But also optic neuritis, often associated with a malignancy. And what you can see here is the MRI is these little speckles, and they have these radial type of fingers that you just don't see in MS. But some of them can look a bit MSy, so again, quite difficult sometimes to make the diagnosis. All right, so those are MS mimics. And I thought you might be interested in sort of where the technologies come from and how we're going.
Can I ask a question?
Yeah, sure, mate.
With those new diseases,
Yeah.
do you have a process of going back through, or is
Or-
it sort of forward thinking?
Forward thinking, largely. We do sometimes go back in that when I do you guys' scans and various things like that, I'm always, if it's not quite typical, I might sometimes do that. Or if somebody has done really well and has never had any more troubles, you know, so little clues might come up, in which case we would test. Neuromyelitis optica we don't miss very often. It's usually very profound. The person gets a lot of disability and then it goes away again, and then but they don't make a good recovery, tend to. But if people make really good responses to steroids the first time, and most patients now, if they come with optic neuritis, we will do it. I have to say that, you know, we'll do 100 and they're all monitor, but it's always good to keep that off.
Can you actually have both MS and Switzerland's?
I think it'd be really hard to know whether you've got both or not. Usually if the MOG, now some people, the assays are not perfect, so we can sometimes get a MOG assay that's positive, but it's usually at a very low titer, and so I tend to just discard it. And again, usually not, but some people who would be diagnosed with MOG initially, particularly children with ADEM, may end up ultimately with a diagnosis of MS. So there's still a bit of crossover, yeah.
Hi, Debbie.
Hi.
Just wanted to ask, the trials that were presented in that slide, would it be for remitting ones or just progressive ones?
Just for progressive, those two.
Yeah. Thank you.
And so part of the criteria is that the patient has to have experienced progression over a 2-year period that is clearly, you know, my little MS base thing that I show where the neurological examination's been slowly worsening over time without identifying any relapses. All right, so symptoms. Symptoms are a big thing for patients, and I put this slide up because I think that a lot of patients say to me, it's all the stuff that people don't see that bothers me. And I think, and you know, I really appreciate people's frustrations that we often talk about the treatments, or we focus on the walking or all those sorts of things, but actually on a day-to-day basis, a lot of this is what actually bothers patients. I think one of the things to say is that we don't have all the answers for this. I've got some ideas about treatment of some of these types of sort of symptoms. I think the main ones I get asked about are fatigue, and the other one I get asked about is brain fog. A little bit sometimes sensory symptoms and pain, but the thing about these things is that if you look at my private practice, one of the most common, and I probably see 2 people a week who have been referred to me with brain fog and fatigue. And the question is, does this patient have MS? And 99.9% of the time, they don't have MS, and there's no neurological disease. So I think what I'm saying is that this is something that is common in our communities, that brain fog and fatigue is a modern problem. But in people with MS, I appreciate that it can be more problematic, particularly the fatigue. I can understand people's frustrations when they come to see us. We've got a 15-minute appointment. And if you look at the work that these guys did a year ago, was it, that we had the fatigue things? The managing fatigue was a 6-week course. You know, you do an hour interview with looking at your sleep, your pain, your medications, your lifestyle, your exercise. So it is a huge sort of conglomerate of things that cause fatigue. And it's not always something we can deal with in 15 minutes, and there's no pill that just fixes it. The classes showed us that we can make a difference to fatigue, but a lot of it is about lifestyle. And that's where the nurses are amazing, because they put aside time to look at symptoms and can talk through. So, are you exercising? Are you sleeping well? Are you getting pain that's waking you? You know, all of these sorts of things that make a big difference to fatigue and to brain fog. I don't understand brain fog. It's really common, and I don't know why it happens. I know that a lot of the drugs that we have don't help it. In fact, they possibly make it worse. So we don't have all the answers, but there are things that we can help with. So this is just a list, and this is very medication, a little bit medication based. But there's also, and you'll be very pleased to see this, there's a lot of other things that we can do for these types of symptoms. So spasticity, yes, there are some drugs for spasticity. They're not great, I have to say, baclofen and drugs like that. But exercise, stretches, pools, and physio can make a big difference to spasticity and contractures and things like that. Fatigue I've talked a little bit about. We have amantadine. Some people find that helpful, and we do use it. Modafinil is not funded. It is funded for sleep apnea and for narcolepsy, but not for MS. It's not hugely expensive, and we do use these, but they are uppers. They are amphetamine type drugs that kind of, some people get really wired with, and it's really unpleasant and they hate it. I like to think that these things can be managed better using the sort of other strategies that we have, but taking a big look at people's lifestyle. Modern lives are busy, and we are on the go all the time with all sorts of stuff. And I think, you know, even in our young people, we're seeing a lot more of this, and I think it's something about our time in life and age. Ambulation, again, we do gait assessments. The Fatradine some of you will be using and find helpful. Doesn't help everybody, but if it does, but again, fitness, stretches, all those things can help. Bladder, we have quite a good bladder service, and we get the urologists involved. We've put quite a few tibial stimulators, for example, for people. And so there's quite a lot of options for bladder. So again, talk to us about it. We may not be able to do it in clinic, but we know where to send you. Sexual dysfunction, again, often people are too shy to mention it. I often will ask people about it, but there are things that we can do to help with sexual dysfunction. It's a very important part of life. Same with bowels. And these sorts of things, again, we do have some stuff. Pain overall, not to belittle those who have pain, and there are some people where it's a big part of their life, isn't a big MS thing, generally speaking, but there are some treatments, but again, it's about working through these. One of the questions I think that people were interested in was marijuana type products. And so I'll give you my take on this. I don't know whether it's the same as everybody's, but when I was in Canada, I used a lot of medicinal cannabis because it was something that they had funded up there. There are not a lot of good clinical trials for cannabis. And one of the problems with cannabis is that up until now, there are something like 600 different cannabinoid products. So when I give you one of these pills, I know exactly what's in it and let you know exactly how it's going to work. When I give you cannabis from the guy next door or the oil person or whatever, it's got different heads in it, different strengths in it, different amounts of cannabinoids, different types of cannabinoids, and also different amounts of THC. Medical marijuana has streamlined that a bit. They can't license it without it being absolutely where we know what the doses are, but it's expensive. And if people say to me, I'd rather go next door and get my mate who grows it, you know, it works just as well. And that's fair enough. I have no problem with that. But if you look at the trials, there's only really one good trial in MS, and that's with Sativex. And if you look, and that was done for spasticity. Now, Sativex has THC as well as cannabinoid in it. So in my experience, very little benefit that we can show comes unless there's THC in it. And the problem with THC is some people don't like it. It makes them feel dizzy, they feel a bit sick, and they're more likely to fall over. So we have to be careful of it. So some of the medical marijuana does have a small amount of THC. The government regulate how much you're allowed to put in. And I think these products can be helpful. And so I have no problem with them. The problem is that a lot of them aren't funded. And so people find their own way through these things. There isn't yet good evidence that just the pure oil that has no THC, only cannabinoid in it, I've yet to see a huge benefit from that, I must admit. But that's my bias. When you put it up against other drugs, for example, if you put Sativex against baclofen, I still think baclofen's a better drug for spasticity, but cannabis with THC is probably better for pain. But for certain types of pain, it's not that good for nerve pain. The trials have been negative. Trigeminal neuralgia doesn't help that much at all. So, but some pain it really does. So hopefully that answered some of the questions people had about that. So I'll just, so that was medical cannabis, contraindications. I don't think there's any major issues. It doesn't interact with the other drugs that we use. It can cause drowsiness at the doses that sometimes are needed to work. It can cause dizziness, bit of nausea, things like that. And so those are the main downsides of it. Some people just find they don't feel good on it. Other people feel good. And in the younger age group, I'm not a big fan, particularly if they're smoking it. But for young people that are still growing their brains, it's probably not great for their brains. We talked a little bit about what the signs of progression is, which is that when I do my examination, I am seeing, but the patient often tells me more than me, I am noticing that I have worsened with certain things, but that I can't attribute it to a relapse. And that's where we would call, what we would usually call progression. But if you look at a patient's cohort that come and say, I think I'm progressing, and then we go, oh, well, let's just wait and see. 80% of them a year later will actually be, oh, no, I'm back where I was. So it's not an absolute given. We've got to see it over time. Why are the symptoms of MS different for some people? I don't know. I mean, I recognize a constellation of symptoms that I think are MS driven, but there are lots and lots of other symptoms that people get that vary between people. Why do some people get profound fatigue and another person says, fatigue's not a big thing for me? Why some people get some pain and others don't? I don't think we always know the answer to that. It's usually probably a combination of a whole lot of different things. What's the current thinking around stress in MS in terms of progression? Well, look, I've been in this game, 25, nearly 30 years. I don't think that stress definitely worsens symptoms, without a doubt. And it also, when people are not sleeping well and they're fatigued more, I don't have a feel that stress causes relapses. Everybody's got stressful things and everybody can remember something that happened before their relapse. But if you plot it out properly, it's a bit like vaccinations. When we actually plot them out, I'm not sure that that contributes hugely. And yes, there is a lot of work in the cancer field about whether the immune system if you're stressed, doesn't work so well, and that may be the case. But I don't know how we measure that. So I think the answer is we live our best lives if we can. We can't all avoid stress, but if we can manage it, then that's good. And you know what? I was talking to a patient this morning in clinic, and she said to me, you know, Dr. Mason, she said, I've just had the worst year. The business went under, there were family issues. She said to me, you know what? Normally, that would make my MS really bad. And she said, you know, I've had the best year in terms of my MS this year. And I said to her, you know, I think I know what this is. And she said, you know, I've just managed it so much better. And I said to her, you know, having a diagnosis of MS and that first few years where you're first diagnosed and you have no idea of the future and you're terrified, you develop a skill set that allows you to cope with other things in life. And I think people with MS are amazingly robust, the majority of them, because they have developed these sort of, and so they manage stress better than a lot of other people. So that's my take on that. Whether I'm right or not might be another matter, but and then, oh, and I know, and you were going to say, should everybody be under the care of a neurologist? Of course they should. Will they ever be? No. You'll have to write to Tifota Ora and to that little wee person called Simon. Which I'll tell you, don't you ever repeat them. I was at a meeting the other day, and somebody said to me they was at a meeting with him, and one of the doctors leaned over and said, do you think his mother gives him a note to let him come up? Being so young. Anyway, you know, in an ideal world, yes, you would touch base. We currently have 900 patients, non-MS patients, sitting on the waiting list, waiting to be seen by a neurologist. I have, as of yesterday, I have 646 of you on treatment between the two nurses and myself, and Zoe Woodward, who some of you might be under, and Dr. Bihari. I think I look after 400 to 500 of you, plus all the other patients we look after. So it's about a numbers game. And this is where people like community, very good GPs that feed you in, and there are things that we can do to help are really important. And these sorts of things, so you are knowledgeable about and you can advocate for yourself when you need something, because we're not always going to be there. And so I think that that's really, you know, and our time is so spread, and it can be quite stressful, you know, particularly if you're really trying to help patients. Once you get to those kind of numbers, and it can be really difficult. Now, the other question, so somebody asked me about the criteria for primary progressive MS. This is the current government criteria. So you have to be diagnosed with primary progressive MS by a neurologist. You have to have a disability score of 2, so you have to have some symptoms, and you have to be able to walk on your walking frame at least 20 meters, and that you have never had other drugs or a diagnosis of relapsing MS. So that's the eligibility criteria. Does that mean that everybody should have this drug? And the answer to that is no. And so you do need to see a neurologist to talk through the pros and cons of it. And then the final thing, this is my slide which I presented to all the neurologists in New Zealand and of course fussed about. But with the new high efficacy treatments, natalizumab, and to a certain and ocrelizumab, we were doing hundreds and hundreds of MRI scans that were all normal. How many of you received a letter from me lots and lots of times? I've just reviewed your MRI scan and I'm pleased to let you know that it shows no new lesions and no new inflammatory changes. Heaps of times. And this has been the thing. So I looked back at all of the data. I looked at the Milan groups and the world recommendations, and the bottom line is that if you are on natalizumab and your JCV negative, you do not need a scan every year. That the risks are incredibly low and the chances of us picking up PML on a random MRI are virtually nil. What we do need is about every 2 years or 3 years, we need a baseline scan so that if you come and say to me, I think I've had a relapse or I've got new symptoms, I've got one to go back to that I can compare it with. Similarly with ocrelizumab, we just don't see new disease activity, very, very rarely. And even if we did, these drugs are not cures, and we're not going to escalate based on one new lesion over 5 years. We expect a little bit of activity. We don't cure this condition. And so for people on ocrelizumab, probably we're going to go to every 2 or 3 years. It depends a little bit on the timing of things. So no, you don't need a scan every year. And similarly with seeing the neurologist, we've moved to an every alternate year, which I think works well for patients because often they're working as well. So 1 year we will do a phone call. If there are any issues, we'll bring you in. But we'll just check on you, make sure everything's fine. The following year we'll see you, examine you, make sure that there's no progression or anything that's changed. And people get used to MRIs and they sometimes will write to me and say, I want an MRI, I want to be sure that my disease is stable. I don't put much store on the MRI because the MRI is, once you've got a diagnostic MRI and then early years, the evidence is that the MRI does not in any way help us with prognosis. So it's not a very useful test, even though I kind of see why people think that it might be something they want to see just to make sure it's not changed. The other thing too is why we don't do spinal MRIs, is the technology is just hopeless. We do different scanners, different regions, and even when we do it in a trial, we get the patient lying exactly the same way on exactly the same scanner, we still get changes. And so the current Magnums, which is the Italian group, is that even in their hands, and they're the best MRIs in the world, they say that scans are not reliable enough to use for judging whether we should change treatment. So we don't do spinal scans unless there's a clear indication for it.
So when you have JCV,
If you are positive,
Yeah.
we do the scans every year.
so what do you see with that? What are you looking for?
Any signs of PML,
Right.
which we have never picked up one in PML, and I'm not sure that it's one random scan a year. It's much more important to have patients report symptoms to us, and that's what we focus on. All right, so let's.
Dolomite,
Yep.
and I have been for.
Oh, okay. So yep, very good question.
And I'm JC positive. I read that
Yeah.
on my system somewhere,
Yeah.
but I haven't had a scan in probably 4 years.
Yeah. So, what about other drugs? So the two high efficacy ones we don't do every year. If a patient is on tecfidera or fingolimod, so tecfidera is a drug that we use in patients who we think are early in the disease or have a very mild disease. So I tend to scan them a bit more often, and the reason for that is that if their disease started ramping up, we would move them to higher efficacy treatments. For fingolimod, again, we do it probably every 3 years, and we might need to just add in another one. So about every 3 years. Again, we're not really looking for anything. We're just doing a baseline so that if you come and see me in 8 months' time and say, I've got all this new changes, I can go back, do a scan and go, oh, actually no, it's just symptoms. So it's really just rebaselining. It doesn't very often change what we do. If a person on fingolimod has a whole lot of new lesions on the scan, then again we might, because we've got other options, we might move up to a higher efficacy treatment.
All right. Can I just ask you about the thing with balance?
Yeah.
You know, why my balance has got really bad over the last few months. So why does MS cause that?
Mhm. Yeah, good question. So some symptoms from MS are because of where the lesions are. All right. So if person has a lot of lesions in their cerebellum or in their brain stem, they tend to get coordination difficulties, tremor, and balance problems. So that's one reason. Patients who have spinal disease often also get balance problems, and the reason for that is that, you know, when I put that little tuning fork on your toes and I find that you can't feel it, then what happens is that when we walk, our body tells us where we are in space from our feet. So all of our orientation is done by eyes, by our feet, and by our head position. Now, if we've got numbness in our legs, then we don't always know where our feet are. And so when you go to suddenly turn, or you're distracted because you're talking to somebody, your balance goes off. And that's the most common reason for it. And if you have lesions in the spine, often the balance is a real problem for people. Is there any other questions? Yeah?
Debbie, on your list of factors, risk factors for progression, you had being female as a risk factor for progression?
Yeah. So,
I thought it was that males had a higher risk of progression, but lower risk of initial diagnosis.
So females overall do better from MS than males. So if you're male with relapsing remitting MS, you have a slightly higher risk of disability. But if you take people with primary progressive MS, for some reason, postmenopausal women get more progression than the men, and nobody quite knows why that is.
And for relapsing MS, if you stay relapsing after menopause, does that
I'm not sure that there's a lot of data around that. I have to say that a lot of the data around progression, you read 10 different papers about it, and everybody's got different risk factors, and they don't always agree with each other. So I think a lot of it depends on the cohort that you're looking at and where in their treatment, you know, were they treated in those days, were they not treated? I think it's still difficult to be sure.
And maybe this is something from another presentation, but you had that great image of the blood-brain barrier,
Yeah.
and the drugs that couldn't
Sit
cross
outside it,
and
yeah.
ones that could. What are the, you know, exercise and diet and things that can actually influence the inside of the brain? Like, I was just curious how, you know, when we're exercising, is that just affecting things outside the brain, or is it actually affecting things inside the brain, and your diet and meditation and other things that we can actually do?
Yeah, good
as
questions. So I think that if you look at the Alzheimer's literature, so that's all an in-brain problem, what you can see is that good diet tends to improve synaptic function in ways that we still don't completely understand. Exercise also, and cognitive stimulation, if you like, improves synaptic networks. So I think a lot of these things that we're talking about that are non-drug related are actually about how we use our networks and how the synapses talk to each other. And a good example of that is if you take a monkey and you tie its hand behind its back and you don't let him use the hand, the part of the brain that is associated with the hand and sensation and the motor function will, over about 2 weeks, regress. Let the hand go again, get him touching things, doing things, and the synaptic area will increase again. And I think that's where, at the level that it happens.
Okay, so it's more about promoting neuroplasticity rather than changing the neuroimmunology aspects.
I suspect there's some immunological aspects to it, but I think it's much more about synapses and networks, yeah.
And with modafinil or any of those other drugs, is there, for those fatigue drugs, is there a price to pay for taking those in terms of reactive oxygen species and like
Not that we know of, no. I mean, those drugs are used for things like ADHD and narcolepsy for 30 years, and I don't think there's been any real negative effects of those. Safety-wise, anyway. All right. Does anybody else have any? Yeah.
I'll just give you the mic, so.
The Mexicana, was it for primary progressive, the drug trial?
Yeah.
Yeah, is that being started here in New Zealand?
It might be in Christchurch.
Okay, is it already started?
Not yet.
Not yet,
No.
so how do we express interest?
Then you would send me an email and I would, so it's a trial that I'm helping with just because I kind of am a neurologist, but the actual nuts and bolts of it are done at a team level. If you are interested in trials, you let me know. I will let the team know, and then what will happen is that somebody who is a team person will call you and go through everything with you and see whether you may be an eligible candidate.
Yeah, I've only just moved down to Christchurch from Auckland, so I'm still waiting for to be on the system for Christchurch neurology.
So is Fiona looking up? Do you know Fiona?
Yeah, I do. She said that Jennifer was sending through a letter. I had an email from the Christchurch, but
So at the end of the meeting, can you talk with Anna?
yes,
And Fiona is working with us as well. We've been talking to her this morning. So if you two connect,
great.
then we'll be good.
Thank you.
Problem solved.
Right, might be time for a cup of tea.
Any other question? Debbie, I have a question for you. I think
Oh,
it's
this
the
might be a
last
hard
one.
one. Oh.
Talking about this overlap of neurological condition,
Yeah.
do you see quite often somebody with progressive MS develop Parkinson's disease? Over the last 2 years, I've had 2 cases that I suspected might be Parkinson and sort of sent them to the GP and neurologist appointment, and they got the medication and they were walking better and a lot of motor symptoms improved.
Yeah.
So do you see it quite often, and what is something that people need to look out for?
So, 2 answers to that. To get MS and Parkinson's is extremely unfortunate, and they are completely separate disorders, and you can be incredibly unlucky. I think I have maybe 3 patients who have both, and that is just bad luck. There are a group of patients with quite established MS that can look like Parkinson's, and they are this group. So I have 2 or 3 patients who look like they've got Parkinson's, but they've had MS for 30 years. And the reason that they look like they've got Parkinson's is not because they've got Parkinson's, it's because they have a lot of frontal executive and planning network disease. And so their motor system looks like Parkinson's. Now, I often will trial a bit of Parkinson medications, but I have to say that the vast majority of time it doesn't help. I've tried it a number of times. They also get slowness of movement, but it's usually EMS, and there's usually a lot of, you do the MRI and there's a lot of disease in the front part of the disease where we plan our motor function, not in the basal ganglia. But of course the basal ganglia is involved in MS, and we don't have good imaging for it because the myelin there is very small, and we know that the thalamus and the basal ganglia are involved, it's just that we don't always see it. So it's always worth a try. I give them some Metapar, and if it works, great. If it doesn't, oh yeah. So if anybody is interested, we've got a few. We're leaving with MS New Zealand some of the subcut ocrevus stuff too, because some of you may have your infusions coming up later in the year, and if you're interested in just having a look at it, it's true for the people on trials and primary progressive as well. So we're switching people over.
All right, thank you so much. We really enjoyed it. I think it was a really informative session. We're really lucky to have you in the community and being really modest. And you're a great speaker. So,
Thank you.
we're looking forward to having you next year. So,
Okay.
thank you, everybody.